How to recognize and prevent deterioration in patients using the ABCDE approach. The RNOH has rapidly reconfigured in recent times to prepare for the COVID-19 pandemic. Elective surgery has been cancelled. We're continuing cancer and unstable spine surgery. We're now accepting adult and pediatric trauma. We run 2 trauma theatres a day, 7 days a week, and we're currently expanding our intensive care and ventilator capacity. The learning outcomes. This talk should enable you to understand the importance of early recognition and treatment of a deteriorating patient in order to prevent cardiac arrest. Assess a patient using the ABCDE approach to identify and treat the causes of cardiac arrest in adults, and also to recognize and treat a deteriorating child. The chain of prevention gives hospitals a structured care process to prevent and detect patient deterioration and cardiac arrest. It helps to reduce intensive care admissions and prevent inappropriate resuscitation attempts. The 5 rings of the chain represent education, monitoring, recognition, calling for help, and response. Early recognition of the deteriorating adult is key. Common factors seen in cardiac arrests are most arrests are predictable. There's a deterioration in up to 80% of patients prior to having a cardiac arrest. Hypoxemia and hypotension are usually present prior to the arrest, and quite often there have been delays in referral for higher levels of care. To illustrate, let's take a look at the observation sheet of this patient. There's been a gradual deterioration in this patient over a 24-hour period. If we look towards the beginning of the ob sheet, we can see a relatively normal blood pressure, a heart rate of 90, and an oxygen saturation of 96% on room air. However, over the course of 24 hours, we get a reduction in blood pressure to 80 systolic, an increase in heart rate from 90 up to 140, and respirations from 15 up to 35. Clearly, this patient has become critically ill, and ideally, intervention should have occurred sooner. But if we don't intervene now at this point in time, this patient will definitely have a cardiorespiratory arrest. We use the National Early Warning Score, or NEWS2, to aid in the early identification of the deteriorating patient. We score various different physiological parameters from 0 to 3. Some of these include oxygen saturation, systolic blood pressure, pulse, consciousness level, and temperature. The total score will categorize patients into low, medium, or high risk. The total score indicates the level of intervention. The level of response is according to the local protocol. The early warning score is dynamic and changes with time. You don't have to wait for a specific score before calling for help. And nurse concern is an important predictor of patient deterioration. With a score of 5 or more, we recommend minimum 1 hourly monitors. The nurse on the ward should immediately call the medical team caring for the patient and request an urgent assessment by a clinician or team with core competencies in the care of acutely ill patients, and provide clinical care in an environment with monitoring facilities. In a patient with a score of 7 or more, this is the emergency response threshold. This patient needs to be continually monitored, and the registered nurse should immediately inform the medical team and an emergency assessment by a team with critical care competencies, and consider transfer of this patient to a level 2 or a level 3 clinical care facility, i.e. HDU or ITU. Causes of deterioration and cardiorespiratory arrest in an adult. These include airway obstruction, breathing problems, and circulation problems. The ABCDE approach to the deteriorating patient is assessing airway, breathing, circulation, disability, and exposure. The underlying principles to the ABCDE approach are: you complete the initial assessment, treat life-threatening problems as they are found. So if you find an obstructed airway, you don't move on to circulation until you have initiated a treatment for that obstructed airway. You assess your response to treatment or interventions as you go along. It's important to call for help early, and when members of a team arise, to use all members of the team effectively. And also what's important is effective communication using SBAR or RSVP. This is the current guidance in our trust on personal protective equipment usage for coronavirus. Aerosol generating procedures are those that stimulate coughing and the generation of aerosol with virus. Additional precautions are required for these procedures. These procedures include CPR, manual ventilation, intubation, CPAP, BiPAP, and tracheostomy insertion. For aerosol generating procedures, we need to have hand hygiene, the use of a long-sleeved gown, an FFP3 mask, eye protection, and gloves. For non-aerosol generating procedures, in a suspected case or confirmed case of COVID, we use hand hygiene, an apron is sufficient, a surgical mask, risk assess for eye protection with each patient, and we use gloves. When approaching a patient, it's important we put our personal safety first and wear the appropriate protective gear. So your first impression, do they look unwell? If they do, they're probably quite unwell. If you ask them how they are and they respond, "Oh doctor, I have a terrible pain in my leg," well then you know what they're verbalizing. They have a patent airway and they have a cardiac output which is perfusing their brain, which are all good things. We look at vital signs such as blood pressure, respiratory rate, pulse rate. We can also look at oxygen saturations and ECG. And we can use the AVPU score, which is they're alert, they respond to voice, they respond to pain, or they're unresponsive. We can also use the Glasgow Coma scale, and we look at temperature as well. Causes of airway obstruction. These include CNS depression, as one gets with strokes, seizures, medications such as opioids, blood, vomit or foreign body in the airway, infection, inflammation, laryngospasm, bronchospasm, and blocked tracheostomy tube. How to recognize an airway obstruction. There may be impaired vocalization. If someone is on a lot of opioids, they may have snoring, or they may be obstructing intermittently. There may be an increased difficulty of breathing. The patient may be distressed or choking. There may be increased effort of breathing. You may see a seesaw pattern of respiration with use of accessory muscles. With partial obstruction, you may have noisy breathing with stridor, and with complete obstruction, there's silence. So treating an airway obstruction, the first thing you do is give supplemental oxygen and open the airway. This is done by the head tilt with chin lift and a jaw thrust where appropriate. Again, be careful with your personal protective equipment. Ensure you risk assess patients for potential COVID infections. Simple adjuncts you can use would be oropharyngeal or nasal airways, and advanced techniques seek advice for the ICU or the MET team, which would include intubation or supraglottic device insertion. The patient may need suctioning of their airway. Causes of breathing problems. Decreased respiratory drive from CNS depression. Again, this could be from a stroke or from opioids. Decreased respiratory effort can be from muscle weakness, nerve damage, from spinal cord injury, for example, restrictive chest defects, pain from fractured ribs and trauma. Lung disorders would include pneumothorax, hemothorax, infection such as pneumonia, exacerbation of COPD, asthma, pulmonary embolism, or pulmonary edema. Recognition of breathing problems. Look, listen, and feel for general signs of respiratory distress. Sweating, central cyanosis, use of the accessory muscles, and abdominal breathing. Check the respiratory rate. Normal is 12 to 20. Greater than 25 is high, or increasing respiratory rate is a marker of illness and a warning that the patient may deteriorate suddenly. Note the inspired oxygen concentration and the saturation reading. Listen to the patient's chest. Wheeze may be present in infection or asthma. Bronchial breathing may be present with consolidation. Crackles may be present with infection or pulmonary edema. The specific treatment of respiratory disorders depends on the cause. All critically ill patients should be given oxygen. Certain patients with COPD, when given high concentrations of oxygen, may depress their breathing. However, they should still be given oxygen due to the deleterious effects of hypoxemia in respiratory failure. Aim for a lower oxygen saturation of 88 to 92% in most COPD patients. If patient's breathing is deemed inadequate, it may be necessary to support their breathing. This is done in consultation with intensive care and may require non-invasive ventilation, CPAP, or intubation. Moving on to circulation. In almost all medical and surgical emergencies, consider hypovolemia to be the primary cause of shock until proven otherwise. Unless there are obvious signs of cardiac cause, give intravenous fluid to any patient with cool peripheries and a fast heart rate. In surgical patients, rapidly exclude hemorrhage. Primary causes of shock would include acute coronary syndromes, arrhythmias, hypertensive heart disease, valvular heart disease, drugs, inherited cardiac diseases, electrolyte and acid-base abnormalities. Secondary causes, the commonest cause would be blood loss or hypovolemia, septic shock, asphyxia, hypoxia, and hypothermia. Recognition of circulation problems. Look at the colour of the hands and digits. Are they blue, pink, pale or mottled? Assess limb temperature by feeling patient's hands. Are they cool or warm? Capillary refill time can be measured by putting cutaneous pressure for 5 seconds on a fingertip at heart level with enough pressure to cause blanching. It normally takes less than 2 seconds for the skin to return to the surrounding skin colour after releasing the pressure. A prolonged capillary refill time suggests poor peripheral perfusion. Check the patient's pulse rate. Palpate peripheral and central pulses, assessing for presence, rate, regularity and inequality. Barely palpable central pulses suggest a poor cardiac output, while a bounding pulse may indicate sepsis. Measure the patient's blood pressure. Sometimes in shock, the blood pressure may be normal because compensatory mechanisms increase peripheral resistance. Listen to the heart. Is there a murmur? Check for other signs of poor cardiac output, such as reduced conscious level or oliguria. Look thoroughly for external hemorrhage from wounds or drains, or evidence of concealed hemorrhage, or fluid loss. Specific treatment of cardiovascular collapse depends on the cause, which should initially be directed at fluid replacement, hemorrhage control, and restoration of tissue perfusion. Look for signs of conditions that are immediately life-threatening, such as cardiac tamponade, massive or continuing hemorrhage, septicemia, and treat them urgently. Insert one or more large bore intravenous cannula and take some bloods for FBC, biochemistry, coag, and microbiology investigations where appropriate. You may also want to cross-match and do an arterial or a venous gauss. Give a bolus of 500 ml of crystalloids such as Hartmann's over 15 minutes if the patient is hypotensive. Disability. Common causes of unconsciousness include profound hypoxia, hypercapnia, cerebral hypoperfusion, or the recent administration of sedatives or analgesic drugs. Review and treat the ABCs, excluding or treating hypoxia and hypotension. Check the patient's drug chart for reversible drug-induced causes of depression. Consider the use of an antagonist where appropriate, such as naloxone for opioid toxicity. Examine pupils. Make a rapid assessment of conscious level using the AVPU method. A is alert, V is response to vocal stimuli, P is response to painful stimuli, or U unresponsive to all stimuli. Alternatively, use the Glasgow Coma scale. You can apply the painful stimulus over the supraorbital region. Check glucose to outrule hypoglycemia and treat if necessary. Nurse unconscious patients in lateral position if their airway is not protected. If patients are very unconscious, they may require tracheal intubation for airway protection. Exposure. Remove the clothes to enable examination, looking for injuries, bleeding, or rashes. Avoid heat loss and maintain dignity. Here's a case example. The clinical setting. Situation: you've received a call from a nurse requesting urgent help with a patient. Background: Bernard is a 75-year-old lifelong heavy smoker and needs surgery for a fractured neck or femur 2 days ago. Assessment: he is responsive, breathing fast, looks unwell, and has been started on oxygen by the nurses. Recommendation: the nurse would like you to assess him urgently. Firstly, ensure you're wearing the appropriate personal protection. When doing so, approach the patient. Airway assessment shows no evidence of obstruction. He's on an oxygen mask. Breathing. He's breathing at a rate of 30 per minute. He's got scattered crackles bilaterally. Oxygen saturations are 88 and 2 litres. You increase his oxygen concentration and request expert help. His oxygen saturations improved to 91%. You assess his circulation, and his peripheries are cool and clammy. His radial pulse is 120 with a BP of 90/40. His ECG shows a sinus tachycardia. You put in an intravenous cannula and you give him a fluid bolus. You take off a arterial sample and you take off bloods for FPC, UNE and glucose. There's no real response in his blood pressure to the fluid bolus. Disability. He responds to voice by lifting his head.
We're now going to talk about recognition and management of the seriously ill child at Stanmore. There are some key differences between adults and children. Children are much more likely to have a cardiorespiratory arrest secondarily to a period of hypoxia and acidosis rather than a primary cardiac cause. The rhythm in cardiac arrest in children will more likely be asystole, and children are much less likely to be severely unwell with COVID-19, although they can carry the infection and be highly contagious and infectious. In children, cardiac arrest is often preceded by a prolonged period of deterioration, which is initially compensated and then becomes decompensated. While in compensated respiratory failure, appropriate blood levels of oxygen and carbon dioxide are maintained, but once decompensated respiratory failure is reached, then saturations will drop and the patient will become hypoxic. Similarly, in compensated circulatory failure, the end organs are perfused adequately, whereas when we continue on to decompensated circulatory failure, the vital organs are no longer perfused and the patient becomes shocked. Once a child starts to decompensate, cardiac arrest can be imminent. So it is important to try and anticipate the deterioration of a child. Observations in pediatric patients are documented. Assessment of a sick child follows a systematic approach similar to that outlined earlier in this talk. Of note, before proceeding to assess a patient, you should always assess whether personal protective equipment is required. The first step is to assess the patient's airway. Airway obstruction can be partial or complete, sudden or insidious, progressive or recurrent. Respiratory rate and work of breathing generally increase in airway obstruction. When assessing airway patency, chest movement does not guarantee that the airway is clear, and air entry needs to be assessed by looking, listening and feeling for air movement and by chest auscultation, but remaining safe at all times. Common causes of airway obstruction are reduced conscious level, foreign bodies, blockage with oxygen delivery devices, nasal feeding tubes, croup, epiglottitis, swelling in the oropharynx from, for example, edema or infection, respiratory tract infections, secretions, congenital or abnormalities. If the airway is obstructed, suction if necessary, and basic airway opening maneuvers, for example head tilt and chin lift or jaw thrust, should be used, possibly with an adjunct such as an oro or nasopharyngeal airway, until more experienced help is available. Having assessed the airway, we then move on to assessing breathing and circulation. When assessing the patient's breathing and circulation, it's important to look at the respiratory rate and heart rate, as an increase in this may be the first sign of a patient deteriorating. We must remember that respiratory rate and heart rate varies with age, fever, whether the patient is in pain or anxious, as well as in respiratory and cardiovascular failure. So have a look at the observation chart and look at the trend over time rather than relying on absolute values. As well as assessing the respiratory rate, we should also look at the work of breathing. There are numerous signs that we should look for: intercostal recession or tracheal tug, whether the patient's head is bobbing, flaring of the nostrils, additional sounds such as wheeze or stridor, and whether the patient looks anxious or tired. Once the patient progresses to looking exhausted, this is a worrying sign, as respiratory failure may be imminent. As well as assessing the work of breathing, we should assess oxygenation using a saturation probe. It's important to use a pediatric appropriate SATS probe, as adult probes may not work or give a false reading. Cyanosis is a late and unreliable sign of hypoxia. Saturations of less than 92% in air are worrying, and less than 90% in air indicates respiratory failure, but be aware that the child may be on oxygen, so it is important to check what oxygen is being administered to give what level of oxygen saturation. As with respiratory rate and heart rate, looking at the trend is always a good idea. Clinical signs of hypoxia and respiratory failure are irritability, agitation, drowsiness, a reduced level of consciousness, sweating, cyanosis, and also hypotonia and bradycardia. If you see these concerning signs, call for expert help immediately. Having assessed the patient's breathing, we now move on to assessing circulation. We should again look at the OBS chart and check whether the blood pressure and heart rate are appropriate for the patient's age. Look at the skin colour, whether they look pale or flushed, whether they feel warm or cold. Feeling the pulses is also useful, but peripheral pulses can be unreliable. Losing central pulses is a critical and pre-terminal event. Also check the capillary refill time by pressing on the sternum for 5 seconds and looking for a capillary refill time of less than 2 seconds. Also important is to assess end organ perfusion, in particular perfusion to the brain and to the kidneys. If the child is irritable or losing interest in surroundings, this may be an indicator that their brain does not have adequate perfusion, and this is a late and worrying sign. Urine output can be a relatively early sign of circulatory failure, so it should be carefully assessed if possible, but this may be difficult, especially in young children. If respiratory and cardiovascular deterioration are not picked up early enough, the child may decompensate. This can lead to an increasing respiratory rate and heart rate, which then rapidly falls. The child may become exhausted and become peripherally vasoconstricted and hypotensive. A dropping blood pressure is a late and worrying sign. The child may also begin behaving differently, have reduced interaction with caregivers and nurses. They may become agitated or have a reduced level of consciousness. Please ensure that the medical emergency team are called prior to this, but intervene quickly if you notice any of these signs. Following assessment of breathing and circulation, we move on to assess disability. Again, age-appropriate assessment is vital. Check with the nurses and parents whether the child is behaving appropriately. If you need to deliver a painful stimulus, rub the sternum or press on the supraorbital ridge. Posturing is a sign of serious brain dysfunction. Pupillary reaction is useful to assess if you are concerned about head injury or opioid overdose. And don't forget to do a blood glucose. To complete your examination, move on to exposure and do a quick head-to-toe examination of the child. In particular, look for any rashes and bruising, do a temperature, and remember to cover up the patient after examination, as children can lose heat very quickly. We're now going to talk about CPR in adult patients at Stanmore Orthopaedic Hospital. The critical thing to remember in this difficult time is that your personal safety is key. Do not start CPR in COVID positive or COVID suspected patients until you have applied full personal protective equipment sufficient for aerosol generating procedures. To remind you, this consists of an FFP3 mask, eye protection, a long-sleeved gown, and gloves. Patients on the wards or in ITU should have a DNAR status documented, and escalation decisions should be made early on in the patient's course. There is a CPR in COVID patients standard operating protocol, which will be available on Grapevine. The ALS algorithm is modified for COVID positive patients, as you can see here. Essentially, ensure your own personal safety. Apply full personal protective equipment. Do not give rescue breaths. Do not get your head near the patient's airway. If anaesthetists are called, we will try to intubate early, and we will do two-handed bag valve mask ventilation with a tight seal to prevent aerosolization as much as possible. When putting the arrest call out, inform switchboard that the arrest call is for a COVID positive or suspected patient. Hopefully, early defibrillation of a shockable rhythm may prevent the need for prolonged airway and ventilatory support. Following the arrest, be meticulous about taking off your personal protective equipment. Use a buddy, follow their instructions, and beware that most contamination occurs during doffing of PPE. Disposable equipment should be thrown away. Other equipment can be cleaned with claw clean wipes. The standard operating procedure for cardiac arrests is below, and this will be available on the Grapevine. CPR in children, similarly, should be carried out with full attention to your own personal safety, so ensure that you have adequate PPE. Of note, we will continue doing rescue breaths in children, as their arrest is often hypoxic and may be helped with assisted ventilation. To summarise, remember to use personal protective equipment where appropriate and to risk stratify appropriately. early recognition of a patient who is deteriorating may prevent cardiac arrest and an aerosol generating procedure. Many patients have warning symptoms and signs prior to cardiac arrest, and anticipating these can prevent arrest. Cardiac arrest may be caused by any of airway, breathing, or circulation problems, and by using an ABCDE approach to recognize and treat these patients, you should have a structured way of approaching a deteriorated patient at risk of cardiac arrest.